Welcome, athletic trainers, to treatment based classifications for the low back. I know that you're busy and I know that we have a lot of things on our plate. And remember, as we go through this, that this is not just one more thing that we're adding to that. It's not just another thing, it could be the thing that makes the difference for you and your patients when it comes to treating low back pain. I'm Chris Gleason, head athletic trainer at Purvis High School and DAT student at Indiana State University. As we talk about low back pain, we can identify some pretty clear problems. Low back pain is the leading cause of disability in the world, and it affects millions of people. And all of them are not the same. Where we may have an ankle sprain that we might be able to treat generally the same across different patients, low back pain just is different. It's also different and difficult to accurately diagnose as far as the potential pain generating structures in the low back. There are a lot. And so we could be having so many things going on from patient to patient. But also, there's a lot of false positives in the selective tissue test that we do and even the imaging. So sometimes you get false positives on MRIs and you don't have a clear diagnosis. So is a problem. And as we look at that problem impacting, it obviously is the leading cause of disability, but it's also a big effect on work quality and quality of life. Uh, and therefore, that leads to a lot of high economic burden just due to healthcare costs and constant, chronic low back pain, or just as we mentioned earlier, the answers not being clear. So constant visits and reoccurrences, but also a loss in productivity. So not able to go to work or not able to do the things that they normally would do. Also, indirectly, you could think from a pharmacological standpoint, it could be directly related to the opioid overuse epidemic that we have because of the opioids that are tossed at this as a treatment option. So, as we look for solutions, I want to offer you the treatment based classification system for low back pain. And what it does is these things: it offers an effective evidence based classification. It moves away from what's going on structurally and goes into more of a grouping category. It is pharmacological, so we're not throwing pills at a problem. And it also focuses on the specific patient goals and eat for each patient. So why we should use this is it matches the patients to the specific treatments based on their clinical presentation. It improves their outcomes compared to non-matched treatments. It addresses the limitations of single intervention approaches for a lot of different patients with low back pain. And it's a low cost conservative treatment, and it's a more active approach where in the past we may have just been more rest and take it easy until it heals, and that's not always a possibility. And it's been shown that motion is the potion to help heal low back pain. So what is it? So it's a systemic approach to categorize low back pain, and it guides our treatment based off of what we're seeing. So we don't have all the fancy tools at the clinic I work at. So we have to just take what we're giving. And it's been around for a while. It first developed in 95 and then kind of revamped in '07. And then lately in 2016, some people say 2015, when there's questions about when the publication came out. But it also incorporates psychosocial factors as a contributing factor to that low back pain, which we can see that it does. It either is a cause of higher low back pain, or the low back pain could be controlling the psychosocial factors. So they have a reciprocal relationship. So how it works is there is a screening process, and we're going to go through this in depth. Initially, as the healthcare provider, you're going to screen them to make sure they're safe for um, this type of treatment, and then you're going to determine the which type of treatment based off of what you're seeing. It's also going to be a kind of a fluid movement here, so you're going to see different presentations from different patients, and you can move them up or down even within the same treatment session. So there's going to be a continuum of their treatment there, and then also it's three different categories. So I want to show you this is super simple, and I'm going to try to help make it easier for you to remember. So first of all, again, as I said, you're going to have to screen them, and if you'll see here, there's a like an algorithm approach. So we got to determine whether or not they have so any red flags, any yellow flags, or any green lights. So we'll say, so the green lights just simply that would be basically they're at a low risk of their symptoms getting worse, and we can just kind of give them a consultation and maybe advice and send them home with a home care plan. And if they come back, then come back and we'll see what happens. But low management um, dedication or cost there for us and for the patient. On the far side there, medical management, we're looking for those red flags, sorry, in those comorbidities that are going on. And if you are not familiar with that red flag screening, we're not going to go over that process in this video. That's another time, but there's a link there on the red flags that could be available in low back pain. But if you identify that this patient is at a low risk and would benefit for uh, the rehabilitation and treatment, then they're going to go through that step right there, the rehabilitation and management. So as you do your evaluation, your clinical evaluation, you're going to start to group them in a category. Instead of trying to pin down the one thing that's wrong, try to group them into a category based off of what the presentation is. And this is where it really becomes more simple to me, where we're not trying to say it's your quadratus lumborum or it's your L3 disc. That's really irrelevant to you, and that's really irrelevant to the patient. Let's try to start figuring out what we can do about this, because to be honest with you, most low back pain is going to fall into a conservative treatment category, and we're going to want to just try to see if we can do something for the patient to increase their quality of life and activity level. So as you can see, this is somewhat of a progression, you can say, and but you can see here as we look at the arrows that it could be flow from one side to the other or back and forth. It's kind of a fluid movement here, but you need to stick with one category, focus on that category, and then if you notice the patient is progressing, then move them to the next category. Try not to bounce around here. Try to focus on one. So we're going to dive deeper into each one of these as we look. But before we do, there's some tools that you're going to need as baseline to get this done. So obviously we think about test and measurements. And when we look at tests, we're going to want to look at their range of motion and flexion extension of the lumbar spine. So you need to be able to evaluate that, whether it's on a table or whether it is on, just a standing position. You're going to need to be able to do the spring test, in which that's going to look for some mobility issues in those lumbar spine, and then also hip internal rotation specifically. Sorry, and you can do that with your goniometer if you have one in your clinic. But we all have our smartphone, and now there's a inclinometer, and it will tell us some of the degrees. And as long as you're doing it bilaterally, you have a standard comparison there. The measures, which are going to be important in this, are going to be measures that are standard and that have been verified and are proven to be accurate. So first, the numeric pain rating scale, we not the most accurate, but it is a guide for us to kind of see where the patient is in their pain experience. The fear avoidance questionnaire, specifically the work section of that, seems to be kind of handy in this decision making process, as well as the ODI. And that low back pain disability questionnaire is going to help us kind of narrow and group these patients in a category. Sometimes we can, if we see the patient is low risk, or we see maybe we just don't know what risk they are, or maybe they're returning back to work or play, and we want to try to make a decision: are they ready for that? Are they low risk? Are they high risk, medium, moderate risk? We can use that start back tool, and it's a very interesting tool to kind of group those risk levels. I put on there PHQ-9 and the GADS. I know that those are, but GADS is not necessarily health related quality of life, but it does have to do with depression. So what I'm saying there is you just need to pick a screening tool that is appropriate for your patient population and that would measure health related quality of life. And so it could be more of a pediatric version if your population is pediatric, or it could be something, a little bit something that you've already have access to that maybe the patient's already filled out so that you can kind of keep up with and the standardized numbers there. And then lastly, of course, a thorough patient history. And we're going to come back. Of course, that patient history is super important in most everything that we do, but in this case, it's extremely important. So let's just jump right into it. Let's look at the symptom modulation first. So as we look through this category here, the patient is going to have a new acute or a recurrent low back pain episode, and it's going to cause them it's going to have significant features. Okay, the patient's typically going to have a pain above 7 on the numeric pain rating scale, a high ODI, which was greater than 40%, and difficulty controlling their symptoms. So if they sit and rest, they don't go away. It's just constant. It's a constant pain, or maybe they can't narrow down what causes more pain. It's just pain, or spasming. And then there's the fear avoidance, the FABQ, specifically that work version, looking greater than 19. So those are going to be some easy measures that we can see to kind of throw them into this symptom modulation category. Patients are also often going to avoid certain postures, and they're going to have limited painful active range of motion. So let's look at some of the treatments that we see here. So symptom modulation treatment goals are to focus on decreasing the symptoms and then maintaining movement. Remember, we said motion is the potion for getting that uh, low back pain out of there. So let's kind of encourage that movement. Where we used to say go home and rest and don't do anything, this one is going to be more of a movement based, and it may be movement on our part as a clinician. So as we look into it, we say active rest. We say we're not going to go lay on the couch or lay on the bed and with a heating pad. We're going to move around. Don't go out and do anything excessive, but try to do your normal activity and try to be mobile, because just that simple motion, plus think about it from a psychosocial standpoint. If you just go lay on the couch, how depressing that is. That's going to be another effect that happens there. uh, Work on their active range of motion, so simple range of motion exercises over a chair or over a table. Some mobilizations. There's been whether it's snags or nags there, with us moving them, and then also directional preference exercise. What directional preference would refer to is if they feel good in flexion, try to focus on flexion exercises. If they feel good in extension, try to do extensive exercises. If they don't feel good in extension, try to avoid those. So try to focus on flexion, and vice versa. I put a manipulation there. There's some literature out that says simply manipulation is better than mobilization in these patients. So trying to just manipulate and do some of those lumbar spine manipulations. And here's an example in the picture: lumbar gapping. And just give them a shot. And if you're unsure of those, plenty of YouTube videos, and also in your manual therapy classes, ask your instructors about those. And then lastly, I put traction. If the patient is having symptoms below their knee, so radicular symptoms, um, then traction may be indicated here. And some people argue that the treatment based classification in this uh, category, symptom modulation, has a fourth or a tail on it that's called traction. And that traction is indicated for patients that may have radicular pain or radicular symptoms. And remember, you're going to have to constantly monitor to make sure that that's not a red flag that we need to be referring for further investigation. As we move into movement control, so you got symptom modulation, then you got movement control. So one of the easy things you can think about with movement control is right here. This person may be hypermobile, and we want to try to increase that quality of movement here. So we're trying to, if you want to simply think about stabilize this person, this is a good way to just simplify this one. So the patient has a low to moderate level of pain and disability that interferes with their activities of daily living. The patient typically has a 3 to 6 pain rating. Their ODI is anywhere from 21 to 40%, and they can stabilize their symptoms. So some little treatment kind of helps it go away. If they sit, it kind of returns back to a base level, but with activity, it gets a little bit higher. That FABQ work related is less than 19, so it's below that 19 mark. And this one includes age a little bit. So obviously they're going to be younger, they're going to do better in this category. If you're old like me, you're just destined for low back pain. But that age under 40 is going to be a um, helpful piece in this category. So patients often describe a low baseline level of pain that increases with activities. We said earlier, and the exam is going to reveal impairments and muscle activation and motor control. So there may be some hypermobile issues that you see on that spring test, or maybe that some instability test and some weak core strength. So you're gonna try to go after on those treatment. You're gonna focus on movement quality, like I said, and stabilization, or as we think of it as simply as the core. So you can see here in these examples, very, very low level core stabilizing strength, and you can kind of progress or regress these activities. But we also include in this some of the neurodynamic techniques that help with that uh, nerve motion within the body. So that also helps decrease the pain for the patient and also increase the mobility. But the stabilization exercises, the flexibility exercises, and those motor control exercises, you can see are simple. All right. So as we roll into our functional optimization, if you want to kind of think about this one as that return to play, and we're really trying to get them back into functional activity, that's pretty easy to remember if you've ever done functional training or return to play training. This one is patient who is relatively asymptomatic, but they can perform their ADLs, but they need higher level. They can do a higher level of physical activity. All right. So this patient has a low pain or absence of pain, 0 to 3. Their ODI is going to be around 20%, or sorry, under 20%, sorry. And then the symptoms are easily controllable. They can take some ibuprofen, or they can rest, or they can, control it. This one also is age dependent here. People below the age of 50 are going to do a little bit better with this one. And the pain is usually aggravated only with movement or fatigue. So as you have a patient returning to maybe a sport, maybe their back hurts as the activity goes on. That's that fatigue factor playing in. They also may have flexibility or control deficits, um, but the impairments of movement, endurance, and strength and power is where your focus is going to be. So as we see in this slide, our treatment goals are going to be return to play or work. They're going to be higher level activities, and they're going to focus on sports / job specific conditioning or activities strengthening. So if you want to think about directional preferences here, as far as they feel better doing this is earlier in that stage. They feel better in flexion, they feel better extension. We're going to do strength training exercises here, and general fitness exercises with aerobic exercises as well. So this, as you can see here, this kettlebell squat, this could just be a functional, squat down and pick up a box and put it on the mail truck, or the Amazon worker, is moving something in the warehouse. So you can see how this would be a functional training exercise. So some other considerations that you just want to really keep in mind. Hopefully, this is kind of simplifying things for you, but you really, really, really want to take a thorough history of that patient, including their family history, to see if there's any relation to their family history, their genetics, sorry, and or maybe they've had injuries in the past that seemed insignificant but do play a factor in this condition. Then also you want to pair your exercises, pair these treatments with exercises. Um, don't immobilize. And of course, we go all the way back to the screening process. If you see red flags, then obviously, you know, do what you need to do there. But we're going to make sure that we do not tell this patient just to sit and don't do anything. So we're going to try to be active, and even if it's something other than an exercise that's not necessarily in that area that we're having issues. So we can do upper body exercises. We can do, lower half exercises, hamstring extension. Extensive exercises on the quads, and leg curls. If it activates the back, we can cut out of that. This is going to be, again, that flow, that continuum. So if we notice for some reason this patient's not doing very well in this category, we can always reevaluate and put them back, to a different category. They're not doing so well in the stabilization, so let's put them in the symptom modulation. So again, try to be keen on that. You're gonna have to observe this patient throughout the process. It's not just a, hey, here, take this home and do it. If there's any radiculopathy there, remember that traction component, but also remember that might be a referral process as well. And don't forget those psychosocial factors. You're gonna have to keep an eye on this patient. Use one of those global outcome measures or the health-related quality of life measures that's appropriate for your patient population, and be sure that nothing is kind of going downhill there. Outcome measures are going to be extremely important on this. They're heavily relied on, and they're just an easy tool to measure these things. If you thought dealing with low back pain was difficult, you throw a couple of these outcome measures in there, you got a whole lot more information to make a better decision. Add it into your very simple, basic evaluation of this patient. And so we can really make things a lot easier on ourselves and on the patient if we just can utilize some of these outcome measures. And then, of course, age is going to be a big factor. If somebody's over that age of 40, 50, they may not respond as well. We may have to, work with other professionals to try to give this patient the best level of care. Now, this is why the evidence is supporting treatment-based classifications. It is improving the outcomes compared to just basic clinical guidelines. So instead of just pinning down, it's your, L2, facet joint that's not functioning correctly, we can group them into a category and have a whole lot better outcomes. The better results with patients are matched to correct treatment. And I know what you might be thinking is, I just started doing this. How do I know if I am correct? Well, according to Fritz, you it does not matter what your level of competence is as far as a clinician goes, your experience. As long as you can do those simple things and read scores and evaluate, then there was no differences between beginner level professionals and professionals that have been doing it for years. So there's not a significant difference there. So, go for this. I encourage you to incorporate this into your practice. It's really easy. Outcome measures, and also using those outcome measures and making a simple evaluation. So, in conclusion, our treatment based classification offers a structured, evidence based approach for managing low back pain instead of just throwing everything at it. It emphasizes individualized treatment based on what they're showing you, and incorporates psychosocial factors, and making sure that we're keeping eyes on them as they're going through this. Is their mental health also being affected by this? But also, it provides us as athletic trainers a valuable, easy to use, and effective tool for low back pain management. And I know I've been stuck in moments where I just did not know what to do. This is something that really you can go. It's easily structured. You can go by it, and if you feel like you need to go back, look through this as much as you can. As much as you can. Speaking of, I'm going to ask you some questions, and I encourage you to pause the video if you need to pause and go back and look at something else. Um, Feel free to do that. First question. So, which treatment based classification exercises are appropriate for the functional optimization category? So, we got the foam roller, the goblet squats, the cat cow, and the upper body ergometer. Take a second, pause if you need to, go back and look if you need to. And your answer is the goblet squat and the upper body ergometer. Remember, in functional optimization, we are focused on sport specific and conditioning. So the goblet squat would be a very specific to a job. Like we said, picking a box up and putting it on a shelf, using good mechanics and technique when we're squatting down to pick something up. And then that upper body ergometer is allowing us to get a cardiovascular component and conditioning without putting a lot of load on the back. And we can get that heart rate up and help return back to a normal function. Next up, which treatment based classification category would you assign to an athlete with a numeric pain rating scale rating of an 8, an ODI of 45%, and that reports their symptoms will not go away while sitting? Pause the video, go back and look if you need to. And that would be symptom modulation. Remember, symptom modulation, we're going to have a high disability index score. We're going to have a high pain rating scale, and our symptoms are not going to be stable. They're not going away with rest. They're constantly in pain, and they're limited no matter what. So that's symptom modulation. And now for the fun part. In the assignment description, there are two case studies. I want you to read through these case studies carefully, consider all the factors that go into treatment based classification and what category these patients will fall into. There are some minor details in there that maybe influence your decision, but I want you to make sure that you can rationalize why you chose the category and what treatments you chose for them.